Hello and welcome again to Tiny Matters with Dr. K. I'm Dr. Kitso Mrubata, a pediatrician, a mom, and co-pilot through this crazy whirlwind we call raising our little children. Today we're talking about one of the most common symptoms in childhood, the cough. We're all familiar with it. The midnight bark, the sniffles turn wheezy chest, and that slight little wet post-nasal thing that just won't go away. To try and unpack this question, I'm joined by my good friend, Dr. Kitso Mrubata, who is a pediatric pulmonologist, a lung doctor that works with all sorts of coughs, from chesty, wheezy coughs to the barking type. Thank you for joining our show. So what is it that a pulmonologist actually does?
Okay, so a pulmonologist is a lung specialist, right? So anything that can affect your lungs, we would be equipped to handle and to help you navigate or diagnose or investigate. But a pediatric pulmonologist means that I am not only a specialist for lungs, but the lungs of children.
Which we know are very different from the lungs of adults.
Very different from the lungs of adults,
Okay.
yes.
All right. So in your opinion then, so I think you're the best person to ask, when is a cough not just a cough?
So it depends, right? There are three main things that will make a cough not just a cough. The first would be the duration. So if a cough is protracted, and in our world, that's anything longer than a month, right? We used to say 2 weeks, but we'll get into why we made it a month now. And then it would also be the nature of the cough. So like you mentioned, a barking cough. That's one of the red flags where it's not an ordinary cough that's likely to go away on its own. And then the third would be if it's accompanied by any other symptoms, like danger signs, which I think we're gonna get into
a little bit later. Yeah. Okay, so I'm a GP or I'm a pediatrician and I'm seeing this child and they have a cough, right? We deal with cough all the time. It's probably one of the most common reasons why someone would bring their child to a doctor. When should I be on the alert that it may be time for me to refer this child on to you?
So if this cough is not responding to any of the usual medications that you would use, if the cough is wet in nature, responds to antibiotics for a short period of time and then comes back again. But that's usually when you would refer to us. So if a cough is again protracted, so if it's longer than 4 weeks,
okay,
and is resistant to any kind of treatment that a GP has tried, if it's different in nature and quality of the cough, and you've also tried the usual treatments that you might give, for instance, for croup, etc., and it's still not, abating. The third would be if it's accompanied by any physical signs. So the main sign that we look for is a sign called clubbing. And that is usually like an indicator of any sinister type of cough. One of the main features that we see with clubbing and cough is usually a syndrome called bronchiectasis, but it just basically is part of a syndrome of what we call suppurative lung diseases, and that's like pus-producing lung diseases. Yeah. So if you see clubbing and you're a GP and this child has also got a chronic cough, then you should probably refer that patient. And then the third would be those danger signs that we spoke about earlier, that I mentioned earlier. So loss of weight, night sweats, any diarrhea or chronic, or if a child is not thriving. So a child's role or job in life is to grow, right? So if this child is not growing and they're coughing, you should most definitely refer to either a pediatrician or a pulmonologist, such as myself.
Thank you for that. I think you've highlighted some very critical points. I think a lot of them are the things that we would see and know that this child is unwell, right? But let's focus a little bit on the wild child, the child that looks okay but has this lingering cough. And that's exactly what I often hear them say. It's doctor, it's just this lingering cough. This cough that comes and goes, but you can almost estimate that in a day he's going to cough 3 or 4 times. What do we think about when a child presents to us with a lingering cough?
Oh my goodness, nothing makes me sadder than a lingering cough, or hearing that, the family sort of adjusted to this cough and are not tuning it out, sort of. To me, no child should be coughing in between illnesses. It's okay to cough. Cough is a symptom, right? So cough is a reflex. It's a protective reflex. It protects our airways from aspiration. That's when things get down your airways, into our lungs. And it also helps you clear, secretions and viruses, etc. But it should stop. Right? So if the cough is always there in the background, I would say that's grounds for investigation, or at least consultation.
And crash syndrome?
So crash syndrome is a tough one, right? Because then you don't know, are you coughing because you keep on going back to school, or are you coughing because there's something underlying, right? So
what's tricky is, I think often there's a little bit of both, right?
Yeah, definitely. And I think, that's when it becomes important to actually consult, right? But in any case, crash syndrome is just a mixture of 2 calamities. The first being a very immature immune system, and then the second being a cesspool of viruses all in one environment. So you put the 2 together and it's a disaster. But even with crash syndrome, when they are home for the holidays, because crash is not, throughout the year, you should see the symptoms improve, if not go away altogether. And also crash syndrome is not forever. So the first year of crash, most parents will tell you, is hell. And it's hell for even as pediatricians, right?
Absolutely.
They're never in school, you're paying school fees, you're not, and yet you're also paying double babysitting or nanny fees. But it should stop, right? As the immune system gets more mature and as it gets, stronger and stronger, it should, the illnesses or the space between illnesses should get wider and wider. And you should always be concerned if your child is now school going age but is still having that quote unquote crash syndrome, then that's not crash syndrome.
Agreed, 100%.
I
think something we see a lot of the time is the younger sibling of the child who's going to crash or school, who basically has secondary crash syndrome as well.
Oh my
so they're sick all the time, and you keep asking the parents, where is the child going? What is triggering this child? Nowhere, the child's at home with me.
Oh my goodness.
This child is sick all the time. But I think that's quite an important entity as well.
Definitely.
Right? So as much as we talk about exposure to daycare, it's also exposure to the child that goes to daycare. Right?
I call that the price of love.
Yeah, absolutely. Absolutely, the price. It's a big price to pay.
Yeah, it is.
So I think for me, where I spend a lot of my time consulting in Soweto, right, and being in an environment where the air pollution index is quite high, I see a lot of this runny nose, the sniffles, the coughing all the time, often a lot of what we call hyperreactive airways or asthma, which we might talk about a little bit. How do you know? How do you know as a parent that, okay, this is something more? You mentioned earlier that, there's those symptoms that just don't get better in between infections. So, that's the child that's always sick. And I did another episode on the child that's always sick. And it came up quite a lot, these allergies. But when as a parent should we be suspecting that maybe we're dealing with something more? Maybe it's allergies, maybe it's asthma.
So I think the thing is to remember about asthma, right, is that it's still a clinical diagnosis at the end of the day. We have all these fancy tests and these fancy machines that can help us support the diagnosis, but at the end, even in adults, it's a clinical diagnosis. So again, you need to consult someone that you trust, right, and with whom you're going to walk away feeling satisfied with what they've told you. And then firstly, the child must be growing. again, going back to what we said before, if they're not growing, something is wrong.
Else.
And then the second thing is if there is a family history. So a lot of the times these things come in clusters that we call an allergic march, right? I know that they're doing away with the term, but I just use it for just ease of reference. Yeah, it still makes sense to me at least. But basically these things go in, so if run in families or come in clusters, right? So if dad has sinusitis and mom has hay fever and grandmother had asthma, but nobody really knows whether it was asthma, but she was always coughing. And now your child has a runny nose and is always coughing, then it's a problem, right? So that's the first thing. The second thing is if it's accompanied by other symptoms. So like if your child has always got ear infections or always has a tonsillitis or snores, then definitely, we definitely get worried about that. Look, allergies are like a contentious issue, but more often times than not, a whole lot of us can kind of hold our own against the air pollution and against the change of seasons without getting admitted. But if your child is getting admitted over and over, or your child is needing to consult the GP like every month, which is actually a history that I had the other day.
Absolutely.
Like every month, then there's a problem there, you know? So again, the duration comes into play again. So no child needs to be coughing longer than a month straight, right? And then also they need to have some periods where there's absolute resolution of symptoms. So yeah. So if those two are not happening, then you need to investigate further as to what is the cause. And then I don't know, do you ask me about asthma? Like, okay. So asthma is a disease of the airways. So the airways are basically pipes that lead down all the way into your lungs. And when they sustain inflammation, meaning that they get red, angry, or swollen, then they're more susceptible to getting tight and getting closed, right? And we diagnose asthma if you respond to asthma treatment, which is more oftentimes than not what is in the names that they give you at the clinic or at the GP or at your pharmacist, right? So if I don't have asthma and you give me asthma treatment and I'm tight, nothing's going to happen to me. But if I have asthma, I will more oftentimes get better. It will be like magic, right? You'll give me you'll give me the asthma meds, you'll give me the nebulizer, and I'll be absolutely fine afterwards, or I'll be marginally better, like remarkably better, not marginally, sorry, remarkably better. But if I don't respond, then that for me goes against asthma, right? And so if your child keeps getting better on asthma treatment, then you need to investigate whether or not they do have asthma. I don't know if that makes sense.
It absolutely makes sense.
Yeah.
It's just always such a difficult thing as clinicians, you know, because an X-ray is not going to show you asthma, you know, and a lot of mothers, fathers, caregivers don't like the name asthma.
No, they don't.
Because they think, oh my gosh, it's forever and ever and ever. And I always kind of try and explain to it that think of it like a chronic swelling of the airways, right? So I always say we can call it whatever you want. We don't have to call it asthma. We can call it something else,
call it
but it's going to respond to the pump. So let's use the pump. And often I think that makes it a little bit less scary, right? And the entity of childhood asthma, so the asthma in children, is that a thing that we should absolutely consider?
I think so. I think because children's lungs are growing, and if you address it early, like what you're saying, it doesn't matter. Like what you're saying is absolutely right, and that's exactly what I do with my patients too. It's like we can label it whatever we want as long as we're using the appropriate treatment. But basically, the good thing about childhood asthma and children in general is that they're growing. I mean, their lungs grow until they're like 8 years old, and for some even 10 years old. And as a result, if you intervene early, you improve the chances of that child not needing treatment as an adult, even like, you get some people who have outgrown their asthma, and what I usually think about that category of people is that you didn't outgrow your asthma. Your mom just gave you asthma treatment.
Absolutely.
And now you're in
the problem.
Exactly. And now you're in remission.
Yeah,
which is the goal. And which brings me into like one of the myths of asthma treatment, which I really, really despise, is that it's forever. It's not forever. It's not forever, and it's not a death sentence.
It's not.
And it doesn't mean you've done anything wrong, and you don't have to be a smoker. It's completely, we can put you in remission. And we can also tell you what to do should you get out of remission.
Yeah.
So
At home nebulization, because every parent wants a nebulizer.
I think nebulizers are more for parents than they are for the child.
I agree.
So I always start off with like the difference between a nebulizer and a pump, right? When you use a nebulizer, like 80% of it you can literally see going up in front of the child. So like
also the child cries, right? And it all escapes. With every cry, the medication escapes.
And then like maybe 20% of that will make it into the mouth. And then of those droplets, like maybe 10% gets lost in the actual oral cavity. And then maybe 5% will make its way down into the lungs. And like if you think about asthma, right, it's your entire airways. So it's from top all the way to the tiny, tiny ones at the bottom. How much of your nibs are getting there?
Yeah.
But I always say, okay, fine, use your nibs, but also use my pump.
Do both.
You do both. But definitely in terms of asthma, for asthma specifically, the pumps are
the gold standard.
They're the gold standard. But I do realize that sometimes parents actually do need a crutch, and they do want something to fall back on. And by all means, use your nibs.
You know what I think it comes from? I think it comes from the in-hospital or at the doctor's rooms experience.
Definitely.
And I always try and explain to them that, I mean, those pumps have, that nebulizer has oxygen.
Yes.
Like, it's probably the oxygen that's really helping you there.
Absolutely.
And the moment you get home, there's no oxygen. I ask them, do you have an oxygen cylinder? If the answer is no, then we probably shouldn't nebulize your child.
Because oxygen is a drug.
Absolutely.
Oxygen is a drug, which is also something that people don't kind of, they're not cognizant of.
Yeah,
but
we're breathing some of it. It
can't be.
Okay, and cough mixtures?
So, I have a different idea. I have different ideas about cough mixture. I have no issue with using a cough mixture if you know what you're treating.
Absolutely. I agree with you.
If you have gone to your pediatrician, your GP, and they've diagnosed your child with X, and they're like, okay, let's use a cough mixture just to get him or her to sleep and to keep them comfortable while they're healing from said infection, then I have no issue with using cough mixtures. Certain cough mixtures, obviously, right? They have to be age appropriate. But I have a problem when you are just suppressing cough, which is actually a symptom, right? Without knowing what you are suppressing, because that could be dangerous. Because if it's like something like TB, if it's something, that like bronchiectasis that actually requires long-term treatment and investigation, then you're asking for trouble, and then you're in essence like kind of shutting down an alarm system without checking to see if there's an intruder or not. And then with that being said, actually the best cough mixture is honey. In over a year, I need to say that please don't give children under a year honey, but it's the one that's been proven to help the most. So please, no garlics, and people give their kids the most disgusting things in the name of cough. But honey is sweet and it's wonderful and it works. But that's where I stand on cough mixtures.
I think my biggest challenge with cough mixtures is just the amount of stuff that goes inside, right? except for the honey one, right? A lot of cough mixtures have, I mean, you look at the list of ingredients and you're just like, it's basically shooting at an ant with an AK-47 and hoping that one of those bullets is going to hit the ant. So often the ingredients are so many and not all very safe for the age of the child that's receiving it. And I think that's often my big challenge with cough mixtures, is that, like, do you even know what you're giving? So yes, we know what we're treating. We know our child's got a viral infection, which is 90% the case, you know, but why do we need alcohol and a bronchodilator and a mucolytic and often that's
theophylline.
The thing. Yes,
and some of them have theophylline, which is like a dangerous drug.
Honestly, I get heart palpitations looking at the ingredients in some cough mixtures. And I think that's why I'm just like, it is something I really had to ask, because I just thought, oh my gosh, I'm so scared of cough mixtures.
Yeah, no, but I also don't think you should get them over the counter. Like, that's why you should go to someone who is a professional, who has the experience and who has hopefully gone through the ingredients list and is going to tell you whether they're safe or not. But
a lot of them are available over the counter, which is another conversation for another day.
It's almost like how the asthma pump salbutamol is available over the counter and
costs
nothing.
that
That grates my cheese, because that lands, like, it's responsible for mortality in asthma. Like, it kills people. You cannot use that pump on its own. And the fact that it's sold over the counter, and this is worldwide, it's not just a South African problem, you know, is criminal. Is criminal.
Because I imagine then you're just using it, you're not even aware, because you have this crutch, like you're saying. So you're using it, you're not aware that your child's actually getting worse.
Exactly. And you're not like addressing the underlying issue.
Absolutely. Yeah.
And I want to say, like, 90% of the kids that end up in ICU have just been using the green pump, the Asaventis on its own, you know, for most of it, because it works. So
and it works quickly.
And it works quickly.
That's why we use it as part of our treatment as well, because it works quickly.
Yes.
You used a scary term earlier, you know, and you mentioned that child that's not growing well, the child that has what you called chronic suppurative lung disease, and you mentioned bronchiectasis as well. What other conditions should we be worried about in a child like that? Because that sounds like quite rare, you know, it doesn't sound like something you hear about every day. But what other conditions should we be aware of in a child that's not growing well?
So what we have to remember, and what I always tell my patients, is that your lungs are the most exposed area in your body, right? You cannot control what you breathe in and out. So to counteract that, your body has to have, like, an amazing immune system in order to protect itself from getting sick, so that I can breathe in whatever it is that I'm exposed to, but I don't necessarily have to be sick all the time, right? So we have to worry, if your child is getting sick all the time and they're not growing, for instance, about the immune system itself. Like, is that functional? Is that doing its job optimally? And that group of diseases we call inborn errors of immunity. And they're basically a group of people who are born with immunodeficiencies that are not acquired, and they are basically unable to defend themselves adequately against disease. And most of the time they will present with lung diseases, because as I mentioned earlier, your lungs are basically, you know, they're open all the time. And we worry if they meet what we call the SPUR criteria, which is severe or persistent, unexplained, and recurrent. Yes, thank you.
You're welcome. Okay, so now I think some practical advice, right? Because I'm a parent, I'm sitting at home with a child with a cough. I have all this information now. We know that allergies are a big cause. You know, we spoke about rhinitis, we spoke about pollution. But in the home, what are practical measures that we can take to reduce the allergens, the triggers, the pollutants that are in our homes?
In terms of triggers, my approach is a little bit unorthodox. Okay. Right? So I don't believe people should get rid of their dogs. Right?
Agreed.
Yes. Or any other pets that they love. I do, however, believe that you also can't let your child just cough and sniff around the dog. So if you've consulted and you're sure that it's the dog or that it's the pet, then you can take an antihistamine. And if it's very, very bad, then I recommend going and actually seeing an allergy specialist and trying to see what they can do about it. Because there's certain things where, like I suppose, because they're very small, I wouldn't want them to go through life with that kind of allergy. So pets are one, and the other thing for me are peanuts. So I know we're trying to avoid peanuts and nuts, but they're ubiquitous, they're everywhere. And
in chocolate even.
And in chocolate even, so you cannot, I would rather not have a small child walk around with a life-threatening allergy.
Absolutely.
Especially in an age where something can be done to maybe not perhaps have them eating peanuts every day, but at least be safe around peanuts,
Okay.
So that's where I stand with those.
So expose them to everything, if you know what it is. And you can give an antihistamine.
Yes, basically. But there are certain things that you can do. So like they recommend wearing sunglasses in pollen season, but I mean, try getting a 2-year-old to wear sunglasses.
Ever.
They being like the allergologists, they also recommend certain covers for your mattresses for house dust mites, and then none of these vacuum cleaners can help you get rid of dust mites. Okay, so it doesn't matter how well they market themselves, I'm sorry, but none of them have actually been proven in trials. So my take on it is, if it causes severe infection, you should probably, go see an allergologist, try see what you can do about it. As far as immunotherapy is concerned. If it's like going to be a day-to-day exposure that you cannot avoid, take an antihistamine, and then treat the underlying allergic rhinitis or asthma, you know what I mean, so that you don't end up in hospital because of it. And then if it's something to do with your mattress, get a cover, and then
do what you can, basically.
Do what you can, but I just don't believe that. I believe kids must be kids.
Yeah.
And if your child is allergic to grass, then for crying out loud, just give them an antihistamine before they go on the grass, instead of just preventing them from having a childhood.
Yeah, exactly.
Which is the point of us, I believe.
Yes.
Like, we're there to make sure to facilitate childhood.
Like a normal childhood.
Like a normal childhood. Yeah. It was normal as possible for your child.
Yes.
But I don't believe in telling them to stop their rugby or stop their swimming.
Yeah.
Then that means I'm just not working hard enough.
Yeah.
I believe anyway.
And I think when we trained as pediatricians, a lot of the teaching was around remove all the carpets, remove the curtains, rather get blinds. I mean, besides the sheer expense of it, I don't know how realistic.
I was actually about to say, I got a flooring quote the other day.
And you're like, I was never saying that to my patients again.
I'm never saying that out loud. You're redoing your floors is insane. It's insane. And also, let's face it, people that smoke are not going to stop smoking.
Yeah.
So I would advise whoever is smoking in the household to stop smoking. Tell them the advantages, and then also to them. But, more oftentimes than not, they have their own reasons for smoking. And I would rather have a calm dad who smokes than the abusive dad. A dad who comes home and wreaks havoc because he's stressed out and he doesn't have his nicotine, and we have things like
we are not in any way condoning
we're not condoning smoking. We're just saying, and there are e-cigarettes now, and the main problem with smoking in children, going back on that, is that it's the third-hand smoke that's a problem. Nobody is blowing smoke in their kids' faces. No one's doing that.
Yeah.
But what you are doing is you're coming back into the house with your smoky clothes and your smoky hands.
Yes, exactly. Right? And it lingers on the surface.
And it lingers on the surface, and that's what triggers your child.
Yeah.
Or the people, your loved ones, you know? So wash your hands before you come in. And I always tell them, get a smoking jacket. If you can afford it, vape.
Yeah.
It's terrible for you.
Yeah.
It's probably gonna destroy your lungs, but it will do so less than smoking.
Yeah. And also it won't
and also
Destroy your child's
it won't
lungs as
destroy your child's lungs as well. Yeah, because it's not going to linger as much. It's vaporized.
Yeah.
But I'm not advocating for vaping of any kind. Vaping is still horrible.
Don't do it.
Don't do it. But I mean, if you have to smoke, if that's what keeps you sane for your family, so that you can do what you need to do for your family, then find ways around it, and these are the ways that I will propose. Yeah.
All right. Okay. If you could leave parents with one golden rule around children and coughs, what would it be?
It would be the golden rule I think I use for everything, and that would be trust your gut. And don't let anybody gaslight you out of not trusting your gut, because us physicians have we have a knack for dismissing patients when we don't know what's going on, right? So if your gut is telling you something is wrong with your child, go with it. Be the neurotic parent, look stupid. At best, that's all that's going to happen. Worst case, you're just going to look silly and your child will be fine, But if you're right and you chose to ignore your gut, you'll never forgive yourself. You'll never forgive yourself. So always trust your gut. And if you leave Kitso's rooms and you're not satisfied with what she has said, get a second opinion. Yes, it's expensive, but get it anyway until you are satisfied as a parent, because at the end of the day, this child's been entrusted to you.
Absolutely.
And you're answerable to them, and how they turn out, lung health and otherwise. So yeah, that's what I always say to patients, and I stand by it. Yeah,
I love that. Thank you. Trust your gut.
Trust your gut.
Well, there you have it. So remember, a cough is the body trying to protect itself. Sometimes it's going to go away and it's all fine, but sometimes it's not. And like the pulmonologist said, trust your gut. Thank you so much for tuning in to another episode. Stay kind, stay curious.